Okay, so when we left off, we were talking about the acidity in the stomach that's used to digest and break down foods and complex proteins and carbohydrates, and how that acidic factor of those gastric juices is offset by the alkaline lining of the stomach. So once you get on the pH scale, you have two extremes. You have acid and you have alkaline. Alkaline resists the effects of acid, essentially, or in this case at least. However, sometimes systems fail. You have a series of small muscles that are part of the peristaltic contractions located at the base of the esophagus, and they are known as the esophageal and the cardiac sphincter. And what they do is they basically hold everything in the stomach that goes in. So let's say you eat a meal and then you lie down or you're hanging upside down. Theoretically, those muscles should be holding those gastric juices and that food in your stomach. Sometimes they fail. Hence, gastroesophageal reflux disease, otherwise known as GERD. And I'm sure if you've watched any television in the past, I don't know, century, you've seen lots of references to medications for GERD. GERD is a backflow or the reflux of gastric contents into the esophagus due to a malfunction of the lower esophageal sphincter. So the cardiac sphincter lies above it. The esophageal sphincter is inferior to that. You also have a set of these at the other end too. Of these valves at the other end of the stomach, but these are connected to the esophagus. When those muscles begin to fail because of time and other circumstances, when that acid can start working up into the esophagus and causing a burning sensation, we refer to it as substernal pain. That's also a pain you might refer to in a cardiac event. And sometimes folks who have GERD think they're having a heart attack because they have a burning sensation in the chest. But it's the fumes and the acid rising up through the esophagus and burning the mucosal lining of the esophagus that are causing that discomfort. So we take medications to use them. They're really indicated for short-term use only, and there should be other forms of therapy to replace them. Having said that, I've seen people who've been taking Prilosec for 30 years. And the problem is when they go off of it, the proton pumps, which are inhibited by this medication, in other words, they stop producing a lot of the gastric acid they should be. When you take the medication away, they overproduce it. So if you've been taking this long term and you try to stop without tapering off of it, you're going to have symptoms far worse than the original ones you started with. So it's a slippery slope on those medications. Definitely consult with a physician if you have those symptoms, and those of you working in healthcare eventually will hear patients report that kind of effect. And you can rest assured they've probably been on Prilosec for a while, or Nexium or one of the other brand names. Omeprazole is the generic name of that drug. Okay, so if we have a problem like that, we're going to do something called a barium swallow. I mentioned this earlier as being one of the first radiological examinations I got to participate in, where I had to actually see the epiglottis of the patient function. So in a barium swallow, we're going to use a fluoroscopy machine, which is kind of like making a very, very low dose radiation X-ray movie. And in this case, it's of the upper GI tract, and it's after swallowing barium sulfate. So they will often have someone like a speech therapist will feed the patient applesauce or some other type of food that has barium in it, and then the patient swallows, and we can pick it up on X-ray, and we can watch the function of the esophagus. We can watch the peristaltic contractions, the function of the epiglottis, all sorts of things to figure out all kinds of different swallowing disorders, food getting stuck or constantly slipping down into the trachea instead of the esophagus, that type of thing. Now, getting back to that lining in the stomach, true, the stomach has an alkaline layer which stands against or is contrary to the acid in the stomach, and that's intended to protect the stomach lining from being dissolved. However, ulcers are something that can cause the stomach to have a great amount of discomfort, and can actually, cause an opening to be formed by the burning of the acid. An ulcer is an open sore or lesion of the skin or mucous membrane. You see several of them here. We referred to GERD a little while ago, and the gastric juices getting up into the esophagus. Well, those can cause an esophageal ulcer because you don't have the alkaline lining, and you see that illustrated here. That could lead to erosive esophagitis, which means the esophagus itself would start to deteriorate, and it's going to be quite painful before it gets there, but some patients will tolerate tremendous amounts of pain. If that ulcer were to get to erosive esophagitis, it could be a bad outcome. So That type of situation we want to see right away. You can see there's another illustrated below that, a gastric ulcer. So there it's happening in the lining of the stomach itself, or in the duodenum, a duodenal ulcer. You haven't learned that word yet, but it's part of the small intestine, and ulcers can form there as well. So they're named by their location, and they're caused basically by the tissue's inability to resist the acid. Pepsia. I think we did learn this at the beginning of the semester as well. It is the suffix for digestion. Dyspepsia would explain some of those GERD symptoms I was talking about. It's painful digestion or indigestion. So it's a type of, it's a way, like we would say dyspnea for breathing. Dyspepsia means basically a stomach ache, and it can take many characteristics. It's an umbrella term to refer to it. Bradypepsia is slow digestion. So sometimes we have patients who are taking chronic opioid medications, and that will slow down the digestive tract and sometimes cause constipation. In that case, it induces bradypepsia, and there's ways to counteract that. Bradypepsia can happen for a variety of reasons. I mentioned one, but there are several conditions, sometimes induced by medicines, sometimes just physiology, sometimes dehydration can cause bradypepsia. So always want to stay hydrated. And we're going to cover that in our next lecture over the urinary tract. So we'll get to that then when we do. Here's an important word for those of you who are going to be working as nurses, dietitians, anytime you might be feeding patients or people in general. We use the prefix post, meaning after. Prandial means meal. Postprandial means after a meal. A very important term in diabetic management, because we ask patients to do glucose readings, in other words, blood sugar readings, before they eat and after they eat. And usually when it comes to after the meal, we want to know what the level is 2 hours after a meal. So we'll chart that as a postprandial. Let's say before a meal, you had a slightly elevated blood pressure, blood glucose at 112. And 2 hours after you've eaten, we would like to see it back around 212. Maybe it comes back at 140. And then we know, okay, the diabetic meds are not working. So those postprandial readings are very important to know, and it's a good word to know, so if it's used in context, you'll know what they're referring to. Or maybe you'll be the person using the word. Reporting postprandials to your doctor. Okay, we're going to jump over to the liver now. Hepato is the combining form for liver, and the diagram you see here pretty much depicts what the liver looks like in a very basic form. That green thing in there that looks like an alien invasion happens to be the gallbladder. And gallbladders will always be colored green in anatomy books. When you actually see one, they're not green at all, but they are here. So, hepatic means pertaining to the liver. A hepatoma is a tumor of the liver. Hepatomegaly is enlargement of the liver. Hepatectomy is excision of a liver. And hepatolith is a stone in the liver. When we talk about stones, we're talking about calculi. You're probably familiar with the term kidney stones. Those are pretty common, and that's usually when people think of having stones in the body, that's what they think of. But you can have them all different types of organs. Anytime there's any type of a cyst, essentially an organ like a gallbladder, which is a pouch that can hold something, calcifications can grow in it. And so hepatolith is the appropriate term to label a stone in the liver. They can also happen in the gallbladder as well. We'll talk about that in a moment. Hepatitis, inflammation of the liver, straight up. I mean, if you look at the word, if you know your suffixes and your combining form, you can see it. There are different types. If you're going to work in healthcare, you are going to be immunized against Hep A and Hep B. Hep B for sure. Hep A is kind of a one that not everyone requires it, but most people do. So I'll run these down, the first three down pretty quickly. They're the most common forms. Hepatitis A is often called, I had a doctor once refer to it as poop-to-mouth disease, because that's how it's transmitted, usually through fecal matter. It's a type of hepatitis that's acute. It comes on really strong. It can resolve on its own. Sometimes it resolves without damage, and it's probably the least threatening of the three here. You can be immunized against it. It's advised you do so. Unsanitary conditions, or someone who's handled contaminated feces with their hands, haven't properly washed their hands and then handled food, could pass it along to someone else or make their own situation much worse. So Hep A, we had an outbreak in Santa Cruz County a few years ago, in fact, in all of California. And at that time, they advised getting immunized for it. I would recommend doing it if you're going to work in healthcare. there are times, regardless of your job, unless you're a receptionist, of course, and even then it's possible that you might come in contact with contaminated feces. And so best to be protected. Hepatitis B is something that every health facility I'm aware of requires. This is a bloodborne pathogen. So you catch this from exchange of blood. So it's a sexually transmitted disease. And also if you're handling blood products, as in phlebotomists. I have drawn more than one patient who was positive for hepatitis B and or HIV. And even in those situations, if you know the patient's positive, you just have to use the correct PPEs to make sure that you don't get infected. On top of that, the medical industry also requires that we have a current hepatitis B immunization pretty much all the time. Hepatitis C is also a bloodborne pathogen, also sexually transmitted. We often associate hepatitis C with drug use or sharing of needles, and that's true that there have been a lot of cases that have been acquired that way. As I said, it's a bloodborne pathogen. There is no immunization. In the past several years, many pharmaceutical companies are selling products that they say cure Hep C or at least reduce the effects of Hep C considerably, and that's a good thing. It's questionable in some of those products whether they really work or not, but they've been out there long enough now, I guess we could say through empirical evidence that there must be some useful medical conditions that they're applied to. Hep C is also, well, any one of these forms of hepatitis I've just described to you, and I don't know much about D or E. You can research those on your own if you like. Any one of these, though, can cause a situation known as cirrhosis. Now, we commonly refer to cirrhosis in terms of alcoholics, because people who are chronic heavy drinkers will cause their liver to become cirrhotic. But in essence, what cirrhosis is a chronic disease of the liver that eventually leads to ineffective liver function as well as jaundice and ascites. And we'll cover those two words in just a moment. Here you see the depiction of a normal liver, here a liver with cirrhosis. And then, of course, the one in the lower right corner is severely affected by cirrhosis. So hepatitis can cause this. So you might get it as a bloodborne pathogen. Hepatitis A is least likely to have this dramatic of an effect on the liver, but it potentially could. B and C are very likely to have this effect on the liver. Even if they can cure Hep C, there is very good, strong evidence of saying that the damage done to the liver will stop at that point, but it can't be repaired. And we only get one shot at a liver. So the takeaway from this one is regarding yourself, your patients, your family, you don't want it to get to this point. You want to protect yourself from these diseases. So protect yourself from hepatitis A, B, or C. And as I've been told by gastroenterologists, binge drinking is the primary way to promote cirrhosis of the liver. I've always thought it would be the chronic alcoholic, and there is some truth to that if it's a heavy doses of alcohol. But he said it's just as likely that you could have cirrhosis of the liver from not drinking for a week or two and then having multiple drinks over the course of a weekend and then recovering. So the takeaway he gave me on that is it is always about moderation and keep nothing in excess. So that's the lesson I got. I am going to pause this because we're going to jump in to define the words jaundice and ascites. That'll take me a minute, and those are our next slides. So I'm going to end right here, and I'll be back in a moment to talk about those two conditions that indicate cirrhosis of the liver.